Invite Dr. Preetam Samant to give his experience. Over to you, Dr. Preetam.
Thank you, Dr. Raja. Again, thanks to AIOS and Novartis for having this forum. Can you see my slides?
Yes, yes,
Yeah.
we can.
So, I was asked to present two cases because I think 6 minutes they were suggested that I should, present two cases. So I've chosen two cases. One is a treatment naive patient, and one is a patient whom we switched over from a previous anti-VEGF to brolucizumab. So first one is a treatment naive patient. Now this lady was bilaterally pseudophakic, came with a drop. Now she's been with me for a couple of years, this routine follow-up. So this was actually her in way back in 2019. She was fine, both eyes are multifocal IOL. But she comes to me in December of last year, 2020, with a drop in vision in the right eye and metamorphopsia. Now you can see over here a juxtafoveal CNVM, very evident clinically. She's a diabetic. You can see some background diabetic changes. Now, this is the OCT. Although this scan is going through the fovea, is showing some intraretinal fluid and subretinal fluid. The parafoveal scans clearly showed the neovascular complex. And I counseled her for loading dose of brolucizumab. That time brolucizumab had just been introduced and we were all looking forward to its results. So I counseled her for a loading dose like we used to do for the previous anti-VEGFs. And she took her first loading dose just then on 27th. I diagnosed it. 2 days later, she came and took her first injection. And then when I saw her a month later, on 2nd February, her vision had already bounced back to about 266 parts. And that day I gave her the second injection. This was a OCT on that day when she took her second injection. Just before the injection, you can see the the anatomy restored back to as if nothing had happened. This was a second injection, and on 16th March she took her third injection as per we had decided. And then on 16th March I told her let's to come back after about six weeks. I thought I will sort of go for the treat and extend kind of a protocol which which I'm more used to following. So she did come back on 3rd of May. Now on 3rd of May she was maintaining 6/6 vision and her OCT was looking good. So at this time I suggested instead of injecting at this time, if the anatomy is looking so good and she's fine, I thought I'll extend it by another 4 weeks. So I told her we'll see you after a month, we'll do the OCT and then we'll take a call. Now she calls me in the first week of June saying that she has COVID and she won't be able to obviously come, but she's fine. Symptomatically, she's fine. And till date, it's been almost Q14 since the third injection on 13th, 16th of March. And symptomatically, she's good. But I'm still waiting for her to come back. I don't have her late. This is the last VAA and assessment I have, that is on 3rd of May, where she's 3 injections of brolucizumab and now she's 14 weeks. This is how it is, 3 injections of brolucizumab, and now today she'll be 14 weeks from the last injection on 16th of March. So this was my first case, treatment naive patient. The second case, interesting scenario because this lady actually is a NRI. She has been with me since again 2018. Now actually there are 2 physicians treating her because a retinologist from USA, whom she has a lot of faith in, sort of helps me and dictates a lot of terms in suggesting the injections. So she was with me since 2018-19 and she's been taking a lot of aflibercept in her right eye and Avastin in her left eye for wet AMD. And I'll cut the story short. I'll start the story from August 2020 last year. Now this was a situation that if you see in the right eye, we were dealing with a little activity here in this area. Rest of it is scarred. You can see the other eye which is scarred. And for this particular activity with OCTs, she required about 3 monthly aflibercept. So I gave her an aflibercept on 3rd of September. I had given her an aflibercept, and her vision was maintained at 636. In the left eye, it was 660. Now I was expecting her to maintain, but on 19th November, a few days before that, she called me saying, "Look, my right eye, the good eye vision has suddenly gone down." And I called her over, and her vision had gone down to about 2 meters, counting fingers. She was definitely saying, "Now I can see better with my left eye." And when I saw, if you see the right eye, there are subretinal hemorrhages here, and there is some kind of an exudative response which is happening over here. Now, I was not able to take OCT scans to this, but there was definitely some exudative response and fluid, like in this particular area. So at this time, again, I said, let's, with consultation of a retinologist in USA, we decided to switch from aflibercept to brolucizumab, and she took her first brolucizumab on 19th of November. And one month later, in fact, few days before that, she called me saying that her right eye vision seems to be a little better, seems to be stabilizing. She came on 29 December, where her vision had come back to 636. Although the central OCT is more or less the same, but you can see this fluid here, which is a little supranasal to the fovea. Actually, you can see it's dry. That particular portion is dry. And then she took, and I was, although I was keen to do it in a PRN fashion. The Her retinologist in USA said, let's go with a loading dose. So she took her second dose on 3rd of Feb, and 3rd of Feb, everything seems to be dry. And this is, if you see how the exudative response has gone, it looks much more dry in this particular area. The hemorrhages seem to be a little less. Symptomatically, she's better. So this is how it was, this is how when we dealt with in November, and this is what it was when she finally took her third injection on 3rd of Feb. You can see this. This is how she has symptomatically improved, and clinically it looks better. So and now she has flown back to the US. So I don't know. I won't have any further follow-up from this patient. So these are the two cases I wanted to share. Thank you.
Thank you, Preetam. That were very, very interesting cases. So, Dr. Giridhar, would you like to comment on any of the?
Yeah, I mean, nice cases actually, Vishali. What I would like to know from the, from what I've understood now is that, as far as I'm concerned, I give brolucizumab on a PRN basis. I'm not giving it probably because I'm not treating it much on treatment naive patients, but mostly on patients who have already been on they are all switch treatment. The thing is that, but what I have seen now is that even on a monthly, one of the reasons why we are a little careful is the rare intraocular inflammation. So now from what I've seen is most of these doctors have been injecting it on a monthly basis. And in spite of that, I think there is hardly any incidence of any intraocular reaction. So I think that's an important take-home message, that basically the risk or the inflammatory reaction is there, but it's quite uncommon. So that's I think an important. I just want to know what's the panel's opinion as far as their opinion on this particular matter, because this is a very important issue, and this is one thing which is really acting as a stumbling block to use this drug more on a very wide basis in many patients, where we know that this drug probably is the ideal choice, but we are a little reluctant because of the possible one-eyed patients, etc. So,
Dr. Giridhar, there has been a recent advisory after.
Yeah, I read that article. Yeah.
So the problem is that even though in the real world we may not be seeing inflammation, only thing is my major concern would be I would love to inject it every 4 weeks, but God forbid if one of my patient ends up with the occlusion or inflammation, would I be able to defend my action
Exactly.
in the recent thing by the company itself?
Exactly.
So that is something, I would like Dr. Dipendra and Dr. Praveen also to give their opinion.
Yeah, I agree with you, ma'am, and I think I agree with Dr. Giridhar also. So we have time and again seen that this drug is really working.
Yeah.
And we have seen that the intraocular inflammation is not too much, yet keeping this advisory in mind, I think we should not just write off the drug also. We need to use it judiciously. We need to keep sharing our experiences and keep learning from them. So slow and steady, cautiously going forward is the answer, I think.
Instead of 4, maybe 6 weeks, what
Yes.
6 weeks of probably.
So that's what Dr. Subhendu's cases were really encouraging. And I think, if I'm not mistaken, most of his cases, as well as one case which Dr. Preetam showed, they are PCV cases. So
Yes.
basic test for any anti-VEGF. You know, anti-VEGFs we know don't work too well where PCV is concerned, and showing good response in PCV cases can be really, really encouraging.
And last comment, Dipendra.
Cautiously and know, keep in mind what is happening.
Thank you.
I think
Yeah.
this is what I have also been recommending for long, that see, the concept of monthly dosing is totally arbitrary. It is not a scientific way. We knew in earlier VEGFs that the duration of the VEGF action used to last for 1 to 1.5 months. Therefore, it was prudent to use the loading dose on a monthly basis. But now with this drug, we know it works for beyond 2.5, it works even beyond 3 months. Therefore, the loading dose naturally needs to be changed to 1.5 to 2 months. This is what I've been recommending ever since I've been using brolucizumab for a long time.
The USP of this drug was the long interval between
Exactly. Very true. And secondly, some of the cases which I also showed were again of PCV. The one which I showed with post 5 injections, then another 3 injections, after 8 injections of ranibizumab, immediate response. So, we need to rationalize. And what I do is I follow them up on a monthly basis with OCT and OCT angio, and see if there is an increasing fluid, then I will go ahead and treat, rather than doing an arbitrary lowering dose.
So I think Dr. Goyal showed some of the OCTAs where the neovascular net almost disappeared. And even in Dr.
Exactly. And so
even in Dr. Preetham's first case of Dr. Preetam, if you see the new vessel is not to be seen, the CNV is not to be seen after the 3 loading dose.
Some of the I'm sorry to cut you. Then some of the cases we have seen from other presenters, we have seen even a very prominent SHREM also, getting disappeared after this injection. So I think everybody has made very right points that this is a drug which we have been waiting for, but it has brought some caution in the sense that there are chances of both thrombotic or inflammatory kind of occlusions, which people are still trying to analyze whether it is immunogenic or the other etiology. But having said that, overall incidence is matching the incidence of infection. So whenever we are deciding about injections, we are anyway very cautious whether it is real life or trials. Good part in real life is you are not bound to give 4 weekly injections, and most of us are actually, even when we advise 4 weekly injections, our patients will anyway choose their appointments and dates. And we also have a flexibility of combining multiple anti-VEGFs. So at which phase of disease suddenly you get a CNVM which is becomes very aggressive after staying quiescent. You have a very good drug to back up even those cases. PCV going wrong direction. You all have seen sometimes PCV is quiet and suddenly it can change gears. So it's a wonderful drug, and I like the idea of Dr. Vaidya of clicking 7 field photographs of these patients. We are doing it in our setup just for the research interest, not that for any other reason, because that's again a very good idea, so that the moment your own data will convince you better than anything.